speaking on the recent advances in the surgical management of breast cancer. I'll be speaking about one advance in the breast surgery and one in the axilla. So we all know that we have moved ahead from the Houstonian principle of radical mastectomy to the Fisher's principle of breast conservation. Thus coming down from radical mastectomy to modified radical mastectomy, then to breast conservation surgery, and now to breast conservation with oncoplasty, which is the new kid on the block, which I will be discussing. So what is oncoplasty? Oncoplasty combines the principles of cancer surgery and plastic surgery with the aim of optimizing cancer care while maintaining cosmesis. Oncological safety is always the priority, and hence there is no compromise on the margins or the oncological safety at any time. So as you can see, there are multiple definitions of oncoplasty over the years with multiple levels described, which led to a consensus definition and classification system of oncoplastic surgery, which was developed by the American Society of Breast Surgeons. So this definition defines oncoplasty as a form of breast conservation surgery that includes oncologic resection with a partial mastectomy, ipsilateral reconstruction using volume displacement or volume replacement techniques, with possible contralateral symmetry surgery when appropriate. So there are two types of oncoplastic surgery. It is either volume displacement or volume replacement. Volume displacement when less than 50% of the breast tissue is removed, and when more, then we have to replace the volume. Again, volume displacement is of two levels. Less than 20% is level 1, and less than 20 to 50% of breast tissue removed is level 2. So this is a paper by Professor Krishna B. Clough, where he has described the classification and quadrant per quadrant atlas for oncoplastic surgery. There you can see, as per the various clocks, arms of the clock, he has described various oncoplastic surgeries for the various quadrants of the breast. So I'll be describing each one of them with a few pictures of the surgeries which we have done at RCC. So basic principle of oncoplasty is that you take a skin incision wide enough to allow wide access for excision and reshaping. You undermine both at the skin level and at the pectoral fascia level to facilitate wide excision and glandular mobilization for reshaping. And the nipple areolar complex is undermined to avoid displacement of the nipple towards the excision defect. A full thickness excision is done so that no margin compromise happens. The gland is reapproximated and the nipple is repositioned, as you can see in this figure. So again, as per the various clocks, there are various techniques such as superior pedicle mammoplasty from 5 to 7 o'clock, lower pole for lower pole tumors, and various techniques which I will be describing in the further slides. So for the upper outer quadrant tumor, we have the racket mammoplasty, where the tissue is excised, the nipple is recentralized, and as you can see, good cosmesis is obtained. For a upper inner quadrant, which is called the no man's zone, usually the round block technique will suffice. As you can see, a donut of skin is removed, the tissue is excised, and the nipple is reapproximated in the center. We also have the matrix flap for this, but it gives a very bad scar, which is why we do not practice it. Then for the lower inner quadrant, we have the J oncoplasty, where again, it is superior pedicle oncoplasty. It's basically superior pedicle or inferior pedicle depends on where the nipple areolar complex is going to receive its final blood supply from. So a tissue is removed again from the lower outer quadrant of the breast, sorry about that, and the tissue is reapproximated and a good cosmesis can be achieved. For 6 o'clock position, we again have the superior pedicle oncoplasty, where you can see that the tumor is removed, the nipple is repositioned upwards, and it gives rise to an inverted T scar. Also for lesions which are near the inframammary crease, we have the Limburg flap, which is a rhomboid flap, which is a very robust flap, whereby we can fill small defects in the inframammary crease region with very good cosmesis. For the lower outer quadrant and lower inner quadrant, very similar to the J oncoplasty, we have the V oncoplasty, where again the nipple is reapproximated and the tissue after excision is reapproximated, giving rise to good cosmesis. For central tumors, there is the round block, which can be used for almost all clocks, which is when the tumor is close to the areola. And for tumors where the nipple areolar complex is to be excised, we have the Grissotti flap, where the nipple areolar complex is excised and the skin below the nipple areolar complex is used to reconstruct the NAC. As you can see, this is a post-op picture of a patient post-radiotherapy. We can later do tattooing of the areola and reconstruct the nipple. There's also for the upper outer quadrant, there are lesions. There is the bat wing flap, which the shape of the flap is like the wings of a bat, and it gives rise to good cosmesis. The Weiss pattern is a little complicated flap, but it's still doable, especially in bilateral breast cancers. So as we can see, it can have either a superior or an inferior pedicle based supply. In this case, we have preserved both upper and the lower pedicle. And this is a case of a bilateral breast carcinoma. And this is the immediate post-operative picture. And this is the picture following radiotherapy. The other volume replacement flaps are usually the perforator flaps, which are based on the most commonly used one are the intercostal perforators, which are based on the posterior and anterior intercostal artery perforators as they go through the muscle and supply the skin and subcutaneous tissue. So this is an ICAP flap, which is an anterior intercostal artery perforator flap, which is, as you can see, we have drawn the flap below. This tissue is harvested and the defect is filled. And the other most commonly used flap is a LICAP flap, which is the lateral intercostal artery perforator flap, where the tissue is harvested based on the lateral intercostal perforator artery from the lateral axillary fold. We usually do the modified LICAP flap. As you can see, the sentinel node biopsy technique can be done through the same incision. The flap is raised and then it is filled into the defect. And this is the final post-operative image. So there's a new concept of extreme oncoplasty, which is breast conserving operation using oncoplastic technique in a patient in whom most physicians opine require a mastectomy. These are generally large, greater than 5 centimeter tumors and multifocal or multicentric tumors. So extreme oncoplasty, there are very few studies and they have very short-term follow-up. And this is a study of 50 patients where they with large multifocal and multicentric tumors by Savioli et al. And the 5-year disease-free survival was 91%, while a cancer-specific survival was 95%. But again, the follow-up is very short. Then with the axilla, when we come to the axilla, the recent advance is we are trying to omit axillary lymph node biopsy and axillary lymph node dissection. So why are we so afraid of ALND? It's basically lymphedema. The lymphedema rate is 16.6% as per the study and meta-analysis by Discipio et al. With shoulder dysfunction, axillary web, and paresthesia as the other complications. So this is a case of our patient who had to undergo an amputation following 10 years following surgery due to lymphedema. So in node negative patients, we already know there is, if the patient is N0 on final HPR, we can just stop at SLNB. If there are micromets, again, SLNB will suffice. And also if there are 1 or 2 nodes positive and the patients are fitting into the ECOS-OG Z11, we can either stop at SLNB or give RT as per the AMROS. So the future in this N0 is the SOUND trial, which is trying to verify if SLNB can be spared in the N0 axilla in early breast cancer. So whether we can do away with SLNB also in a node negative patient with early breast cancer. And it's trying to verify if adjuvant therapy can be planned based only on the biology and if the quality of life is improved by omitting axillary surgery. So this is in patients who are N0. So in patients, there is a new trial called the TADEN trial, where just targeted axillary dissection in early stage node positive breast cancer patients. So here we are trying to avoid axillary dissection even in the node positive patients. So this is a prospective multicentric study, which has T1, T2 breast cancer patients who are N0 on palpation, but had 1 to 2 suspicious nodes on ultrasound and a biopsy proven positive node. And they implant a radioactive seed, iodine 125, in their clipped node before surgery. And at the time of surgery, both the sentinel node using either the blue dye or the technetium for radioactivity, as well as the clipped node is retrieved. And then then they're trying to ascertain whether rest of the axillary clearance can be avoided in these patients. In post-chemo patients who are N0, there are different set of concerns. There is possible alteration of the lymphatics due to the neoadjuvant chemotherapy, which can lead to a poor identification rate. And there can be differential effect on the sentinel and non-sentinel nodes, which can lead to a high false negativity rate. So in patients who were clinically N0 prior to chemotherapy and remain clinically N0 post-chemotherapy, the SLNB is an accepted modality of treatment. But in patients who are clinically node positive prior to chemotherapy and then convert to negative after chemotherapy is where the question lies. So there are multiple studies, and you all know of ECOS-OG, Sentina, and SN-FNAC, all which have a higher false negative rate and a reasonable sentinel node identification rate. So conclusion from these studies is that the use of dual tracer lymphatic mapping, identification and retrieval of more than 2 lymph nodes, IHC of the nodes, if it is done, then probably we can bring down the false negativity rate. And if all these three are not reached, then a performance of a complete axillary lymph node dissection is required. This gave rise to the principle of targeted axillary dissection. So in patients of the ECOS-OG Z1071 studies, in some patient, a clip was placed at the initial node biopsy in 203 patients, out of which 83% of the patients with node positive disease pre-chemo and at least 2 sentinel nodes resected, the clip location was confirmed in 141 cases. So when the clipped node and the sentinel node were the same, the false negativity rate was 6.8%. When the clipped node was in the axillary lymph node biopsy dissection, the false negativity rate was 19%. And when the clip is not identified at surgery, the false negativity is 14%, and the clip was not placed at all, the false negativity was 13%. So basically, if the clipped node and the sentinel node were the same, the false negativity rate is 6.5%, so which is quite low and acceptable. So which gave rise to the targeted lymph node biopsy. So targeted lymph node biopsy is selective removal of the metastatic lymph node, which is marked before neoadjuvant chemotherapy. And targeted axillary dissection is targeted lymph node biopsy combined with sentinel lymph node biopsy. So based on this subgroup analysis of ECOS-OG, Caudle et al. Conducted a study whereby their goal was to see whether the pathological changes seen in the clipped node after neoadjuvant therapy reflected the responses in the entire nodal basin, with the hypothesis that surgical removal of the clipped node would improve the accuracy of the nodal staging in these patients compared with SLNB alone. So patients with biopsy confirmed nodal mets with clip placed in the sample node were enrolled into a prospective register. 208 patients enrolled, 191 underwent axillary lymph node dissection, and 120 had residual disease. So post chemo, all these patients underwent an SLNB plus a targeted lymph node dissection. So this is the patient, as you can see, the clip was placed and then an iodine 125 seed was placed to identify these nodes intraoperatively. And this is specimen radiograph of the same. So when only SLNB was done, the false negative rate was 10.2%. But when a targeted axillary dissection was done, the false negative rate was only 1.4%. So there are multiple techniques to clip the nodes. One is the most commonly used is a normal clipping. Then there are carbon suspension tattooing of the nodes, wire localization, ultrasound visible clips, magnetic seed localization, iodine 125 localization, and Savvy Scout, which is by a reflector technique. So as you can see in this image, the nodes have been carbon suspension has been injected into the node pre-chemotherapy, and then the nodes are identified. It is then seen on with a probe when they are using the sentinel node. This is the blue dye as well as the carbon tattoo, and this is the carbon which is seen inside the node on the HPR. This is a guide wire localization of the node, and this is hydrogel which is used in ultrasound marking, which basically starts off as a small little clip, and then it absorbs water and swells to this dimension and can be seen on ultrasound. The other most commonly recently used technique is a MACSEED, in which a magnetic probe is required, and the clip is magnetized when the probe is brought close to it, and then the node can be identified. The other one is a micro impulse radar and an infrared light. All these are newer techniques which are used, and multiple trials are going on of the same. So we have our own technique which we have tried in a pilot study, and we are currently doing the prospective study of the same, where we use the tattooing of the breast. We normally tattoo the breast prior to chemotherapy to identify the site of the tumor post-op. So we use the tattooing of the breast, as you can see in this node, to identify the sentinel node, and we're trying to see if that can act as a targeted axillary dissection as well. So as you can see, targeted axillary dissection has made its way into the NCCN guidelines as well. And now the future, again, there are recent studies where we are trying to avoid axillary dissection if the node is positive. So even if the targeted axillary node is positive, so far we have been doing a completion axillary dissection. So whether axillary dissection can be avoided even if the node is positive post chemotherapy. So these are a few of the studies. This is NACBP B51, Alliance 11202, and the AXANA trials, which are looking into this. So the AXANA trial is a multinational prospective study which enrolls C node positive patients which undergoing neoadjuvant therapy who are converted to YCN0, and to aim is to assess the impact of different surgical staging procedures in the axilla on the oncological outcomes and the health related quality of life. The axillary staging procedures and treatment modalities are chosen at the discretion of the treating physician. Then there is the Alliance study, which is looking at clinically T1 to T3 N1 patients. They're giving neoadjuvant chemotherapy. The patient undergoes BCT or mastectomy. And if the sentinel node is positive, they are randomized into axillary lymph node dissection or no further axillary surgery, breast and chest wall and nodal RT. So we are awaiting the results of these trials to see whether we can actually avoid axillary dissection even in these node positive patients. Thank you.
Thank you, Dr. Xena. I think we'll have the discussion at the end. So we'll go to the next topic. Dr. Rajiv Kaya is an Associate Professor of Radiation Oncology of Breast Services RCC, and he's one of the dynamic faces of the Radiation Oncology Department as well as the Breast Clinic of RCC. Dr. Rajiv, over to you, Dr. Rajiv. You have to unmute, Rajiv. So we can see your slides, Rajiv.
Yeah.
Thank you. Go ahead.
So thank you. Without wasting time, let me go directly to the topic. So if we think about the radiation oncology update in breast cancer management, we'll have to think about a lot of facts. But unfortunately, because of the time constraint, I'll have to limit and I'll have to go superficially in some of the areas. And the very important point that Ratsina has talked about the impact of neoadjuvant treatment regarding the decision on the axillary management, and where the radiation oncologist has got the same value, what to do with the radiation for these patients after surgery. And the second most important concept were, can you avoid treatment in elderly women, and that too with a good biology. And as you all know, we have started thinking about the hyperfractionation, that is the reduction in the number of radiation with a very high dose per fraction. So how much hypo, and is it time to think about the axillary partial breast radiation is that standard. And there are so many number of techniques where how can you reduce the toxicity of the radiation treatment. So I think this is the area where Rexina has talked regarding the question of post-mastectomy radiotherapy after neoadjuvant chemotherapy in breast cancer. So there is, as she rightly pointed out, we'll have to wait for the better prospective randomized trials. So we have some retrospective analysis of the 3 major prospective randomized trials, and where all has shown that in locally advanced breast cancer, especially where radiotherapy reduces the loco-regional rates in breast cancer patients who receive a mastectomy after neoadjuvant chemotherapy without any improvement in the disease-free survival. So as you all know, the all radiation indications are purely basically depend upon the pathological stage of the disease. And we also started thinking about the biological aspect of the tumor, where we know the aggressive biology has got a more chance for loco-regional relapse. So basically there is no much survival advantage of radiation, rather it produces the much of the loco-regional benefit. So for a patient who receives neoadjuvant systemic therapy, especially in node positive individuals, and those even turns out to be YPN0 following neoadjuvant chemotherapy, post-mastectomy radiotherapy can improve overall survival in patients who have a T3, T4 disease or multiple node positive disease. And especially there is this residual invasive breast tumor after neoadjuvant chemotherapy. So in this subgroup, there is no much of confusion from the major retrospective areas that the radiotherapy definitely reduces the local relapse. So as she rightly pointed out, the some of the important points there about the EXOC clinical trial, where what is the impact of radiotherapy, and it has included a different variety of patients. But if you look into the subgroup of each these patients, we can't clearly draw a definitive conclusion because the number of patients included in the subgroup are very low. But what we can see that still the radiotherapy has clearly shown for the reduction in the loco-regional relapse without any added overall survival benefit that is remaining same for the regional nodal relay aspect also. And the chance of loco-regional relapse is much higher for those patients with triple negative breast cancer compared to luminal types. So the only question where we do treat neoadjuvant systemic therapy for an early stage disease, even in N0 disease with highly aggressive disease like triple negatives or HER2 positives. In those patients, what to do after a mastectomy or a conservative surgery is a question. For a conservative surgery, it's a mandatory for the patient to receive radiation, but after mastectomy, it's a big question. So we have to wait for the B51, where what happens to the radiotherapy aspect also when the patients turn out to be node negative, or the alliance trial will have to take a decision based on these prospective trials. And one of the important point as radiation oncologists always think about that, are we getting a decreased response or decreased results because of the delay in reconstruction or the delayed post-mastectomy radiotherapy after reconstruction. So this was again assessed in this particular trial. There is no much of loco-regional recurrence because of the delay in the reconstruction. So even the survival is not compromised. So no difference in loco-regional recurrence or disease-free survival or overall survival because of the reconstructive aspect. So after neoadjuvant chemotherapy for all locally advanced breast cancer or any T3, T4 or node positive disease, there is reduction in the loco-regional relapse by the addition of radiotherapy. And triple negative breast cancer was associated with a higher loco-regional relapse, and there is no associated benefit with the survival. And de-escalation of radiotherapy in early stage high risk disease or those who have YPN0 remains unclear, and there is no effect on delay after reconstruction in RT scenarios. And now the second concept of can you avoid radiotherapy in elderly women with a good biology, and whether the adjuvant radiotherapy alone was equivalent to adjuvant hormone therapy alone. So there are 3 randomized phase 3 trials where this concept was addressed, like CLGB, C9343, Prime 2, and the Austrian prostate cancer study. And there is no survival advantage with addition of radiotherapy to hormone therapy, but a consistently showed a local control benefit of radiation along with the hormone therapy. Now, again, we are now moving in a phase of molecular subtyping and the treatment decision based on the subtyping. So do we have any data for radiation to think about de-escalation based on the biology of the tumor? So even there is no prospective data available. This is a retrospective analysis of 327 patients, which have clearly looked into the difference between the luminal A versus luminal B subtype of patients who have received radiation, and there is clearly no significant difference in 5-year locoregional relapse or distant metastatic relapse or disease-free survival and overall survival for a patient with luminal A. But there was a difference, or there was a benefit with the addition of radiation in luminal B subtype of disease. So ultimately, there is a concept of evolving concept which has to be tested in a prospective way. Luminal A type early stage disease patients may not benefit from radiotherapy. Without radiotherapy, luminal A type patients have a better overall survival and disease-free survival than luminal B. And radiotherapy can reduce the local regional relapse and improve the disease-free survival and overall survival of luminal B type early patients. Now, the question of whether adjuvant radiotherapy alone was equivalent to adjuvant hormone therapy alone. And this was addressed in the NSABP-B21 trial. The radiotherapy reduced the cumulative incidence of ipsilateral breast tumor recurrence. So when you look into the data, you can clearly show that the much reduction in the local regional relapse has happened when the radiotherapy has combined with hormone therapy. Again, there is no much difference in the terms of survival. So again, there is a large retrospective national cancer database on this particular aspect, which clearly evaluated the outcome of the patients more than the age of 70 years with 2,995 patients. And there is no significant difference in the DMR and OS between the two subgroups. And there is a significant difference in the 5-year local regional relapse free survival. So as far as radiotherapy in elderly is concerned, radiotherapy alone, there is non-compliance with our discontinuation of hormone therapy is the only situation where you can consider radiotherapy alone. And hormone therapy alone, that is the luminal A, which is the only subtype more than the age of 70, may not benefit from radiotherapy. There is a concept from the retrospective data. And the ideal way is always radiotherapy has to be combined with the hormone therapy, and there has to be a definitive indication or benefit in luminal B and other biological subtypes. Now, moving on to the third concept of fractionation, how much hypo in breast radiotherapy. And as you all know, we have moved from the standard conventional fractionation of 50 grain 25 fraction to 40 grain 15 fraction based on the START trials, and which are clearly show either the Canadian trial as well as the RMS trial with 12 years of follow-up, that it has clearly shown that it is safe and effective. So there is reduction, there is equivalence to the conventional fractionation in terms of the local regional control, as well as the toxicity pattern. So the current standard of care is 40 grain 15 fraction, where you give radiation for 15 days, that is 3 weeks of treatment with 2.67 centigrade gray per fraction. So if the future is still 15, are we moving forward to the FAST trial where we give a 5.7 gray each week, a single fraction for a 5 weeks period, or little moving fast forward? That means we are ending up the treatment within a 1 week program where 5 fraction is enough. So coming to the FAST trial, they have published the 3-year findings mainly on the normal tissue effects, where 50 gray standard arm was compared to the 30 gray and the 28.5 gray. And they have looked into the various aspects of breast shrinkage, breast edema, telangiectasia, and the breast induration. And it has clearly shown that at 10 years, there is no significant difference in normal tissue effect rates after 28.5 gray in 5 fraction compared with the 50 gray, but the normal tissue effects were higher for the 30 gray in 5 fractions. So once weekly 5 fraction schedule of whole breast radiotherapy can be identified that appears to be radiobiologically comparable for a normal tissue effects to a conventionally fractionated regime. Now, moving a little fast forward, there happens to be 3 arms where 1,200 patients randomized in each group, where it has clearly shown that 40 gray combined with the 27 gray or 26 gray in 5 fractions. It has clearly shown 26 gray in 5 fractions over 1 week is non-inferior to the standard 40 gray in 5 fractions over 3 weeks for local tumoral control. And it is safe in terms of normal tissue effects up to 5 years. So mind you, these 2 trials have got limited follow-up as of breast cancer is concerned. And you have to be very much cautious by selecting the patient appropriately for these protocols. That is very important. So moving much more hypo is the time to think about the accelerated partial breast radiation, which is called APBI. As you know, there are an empty number of techniques by which you can treat tumor bed alone by interstitial catheters, mammoth site, and even with external beam radiotherapy or intraoperative electrons and so many techniques with different dosage patterns. We won't be able to compare one with the another. So APBA has evolved to be a convenient, cost-effective, acceptable treatment option in patients with the appropriately selected for this technique. So further long-term studies will provide more information on the safety and efficacy and toxicity. So right now, whole breast radiation should remain the standard. And for patients with favorable breast cancer that are unable to undergo a 3 to 6 weeks of radiotherapy, yes, APBA has to be a reasonable alternative option. And it is very important to look into the this particular trial where IMRT is one of the external beam radiotherapy has used as an APBI technique, and which was presented in the last San Antonio conference. This is a Florence trial, and which has given a 10 gray in 5 fraction to the 30 grain 5 daily fractions as APBI to the tumor bed. And the primary endpoint was ipsilateral breast tumor relapse, and secondary endpoint were all survivals. And they have also looked into adverse events and cosmesis. The present 10-year analysis showed no significant difference were observed in any of the primary or secondary objectives, and the grade 2 or higher acute events were 37% in the whole breast radiation compared to with just 2% the APBI technique. So both physician and patient reported good or excellent cosmetic results. Again, I want to emphasize the points that ideal patient selection, suitable patient selection is very important. So in the future, APBI might be considered as a standard alternative to whole breast radiation in low risk and very low risk early breast cancer patients. 10-year results of the Florence trial support partial breast radiation. Now moving on to the reduction in the toxicity. Cardiac safety is one of the major concerns for the left-sided breast cancer patients, where absence of a lower dose threshold for a radiation-induced heart disease is a big issue. So how much you can reduce, that is better. There is no gold standard dose value, which is the standard for heart dose. How much you can reduce, that is better. Because if you look into all the hypofractionated or the other clinical trials, there is one of the important toxicity, which is cardiac ischemia, as the late toxicity with the left-sided heart radiation. So there are umpteen number of techniques where which you can reduce the cardiac dose. One is about the breath hold technique. Among the different breath hold techniques, voluntary breath hold technique, which is we call deep inspiratory breath hold, which clearly reduces the mean cardiac dose. If you reduce the mean cardiac dose with 1 gray, you are going to reduce absolute 7% risk of cardiac damage. So reducing the mean cardiac dose from 2 gray to 1 gray in a 50-year-old woman with a 1 cardiac risk factor can be expected to more than halve the absolute risk of radiotherapy induced acute coronary event by 80 years from 1.1% to 0.5%. So it's time to clearly look into the cardiac dose when we plan left-sided cardiac treatment. And the most important thing is regarding the other technique of prone breast radiotherapy, which even at RCC we started a pilot trial and already have included around 22 to 23 patients right now. And we are comparing the supine versus the prone techniques, especially for the left-sided patients, and various aspects of suitability and the practical aspects, all these things. And it has clearly shown from the literature that it has shown reduction in the dose to the heart which are received. And moving on to the more important toxicity reduction of lymphedema, how can radiation oncologists contribute to the principle where accelerate nodal irradiation when and where to respect? The most important point is that try to limit the axillary treatment either with the surgical modality or with the radiation modality. If the surgeon has adequately addressed the axilla, never ever treat the axilla. Or if we want to treat the axilla or we treat the other areas, try to reduce the radiation toxicity to the important point to the axilla. So the radiation oncologist should clearly know the anatomy of the axilla and when and where to respect. And we also started looking into the ARM node and what is the percentage of the ARM node that is getting the radiation dose, and how can you reduce the radiation dose to the ARM node, because it has shown from the literature that if you reduce the radiation dose to the ARM node, we can clearly reduce the chance of lymphedema. And many of the trials where they have looked into the different plants, only the whole breast plants, all breast plus axillary plants, what is the dose that is that the ARM has got, and if you reduce the dose to the ARM, definitely if you try to reduce the ARM away from the axillary fields or the tangential fields, you can reduce the toxicity to the axilla. Again, look into the most important points there, which is called the axillary lateral thoracic wall junction, which is concerned as the important area where there is a dose to this region was associated with the more lymphedema. So there is a significant dosimetric variable for the ALTJ as a critical area, which can even be included in the tangential field. So you can, if you can reduce the higher dose to this region, again, you can reduce the toxicity as much. Now, another area, how can you protect the contralateral breast? Yes, that is also very important, especially when you treat young individuals. So there are so many methods, dosimetrically or in the radiation parameters planning, where how can you reduce the mean breast distance? So how can you arrange your fields so that you can reduce the dose to the contralateral breast? That is the importance of planning a beautiful 3D confirmed radiotherapy over an IMRT or IGRT plans, where you are going to get a low dose region for these IMRT plans to the contralateral breast, which you can avoid in a nicely planned 3D confirmed radiotherapy. So that is also very important concern. So in 2021, after NACT, there are attempts to de-escalate in breast radiotherapy, but we need to wait for robust data from the randomized controlled trials in some of the areas. And there is an emerging thoughts where elderly luminal A may not benefit from breast radiotherapy, and hypofractionation has already become the accepted strategy as of now for the 3-week schedule. And there is always the concern of better cardiac and toxicity reduction when you hypofractionate. That is very, very, very important. So outside the clinical trial, yes, whole breast radiation remains the standard of now, and APBI might be considered as a standard alternative to whole breast radiation in low risk early stage breast cancer. Thank you.
Chandramohan, can I just ask one question to Rajiv?
Yes.
Yeah, Rajiv, thank you. As always, an excellent talk. So, Rajiv, so what I gathered from your talk was that from all the data which has been published, what you are actually gone through, you mean to say that radiation is not giving any overall survival, but it is only giving local control. Is the am I true in that statement which I made?
That statement is applicable to the local advanced breast cancer patient who have given neoadjuvant chemotherapy and the surgery. Then you look into the reduction on how much, what is this quantum of the benefit these patients are getting. Absolutely, there is a local regional control benefit, but that is not going to change into a bet of overall survival advantage. This is in comparison with the early stage breast cancer, where you look into the large meta-analysis early breast cancer trial group, which has shown clearly there is a reduction in the, there is a benefit in the survival, and there is also reduction in the breast cancer mortality.
Okay, so you mean to say that for localized early stage breast cancer, giving radiation, we have an overall survival. But for a locally advanced breast cancer patient in whom we are given neoadjuvant chemotherapy and in whom we had a good response, in those group of patients, radiation is giving only a local control, but not a systemic advantage is not there.
Yeah.
Okay. Yeah. Thank you. We will have a discussion towards the end because I'm not discussing a case, but then a couple of scenarios has been discussed. So we will have the discussion if time permits towards the end of this meeting. Thank you. Thank you, Raj.
Thank you, Dr. Rajiv. And I think it is a very fantastic talk. I think you and Rexina are mainly alluding into the delimitation of surgical and radiation oncology practices to avoid toxicity. And that's the right direction the world is moving, and a lot of advancements. Since I don't practice breast cancer treatment, and just like every year I'm coming listening to you guys, and I'm knowing that things are really changing a lot. And really thank, and I also acknowledge Rajiv as one of the good speakers, where he had a fantastic speech in the last public meeting, and it has more than 25,000 views. Rajiv, really congratulate you on that. And coming to the next speaker, Dr. Aparna Rajyadeksha is a medical genetic expert, and she's working in Metropolis Healthcare, Mumbai. And she has tremendous experience in the clinical pathology and the biochemical genetic research. And she has been working in US with a commendable CV. He was member of so many committees, and really she's an asset to India. Now she's with us in Metropolis Healthcare, and she'll be talking about the role of NGS in breast cancer. Over to you, Dr. Aparna. Aparna, you have to unmute your mic and speak.
There we go. Okay. So the talk is basically NGS and decision making and management of breast cancer. Now, when I first started the talk, I said, should we do somatic? Should we do germline? And really all of it is part of management in breast cancer. So I think this comes at a very timely point, because when Globocan did a study in 2018, they found the breast cancer cases increasing. And if you look at the lower income, lower middle, upper income, higher income countries, it's all increasing. India comes in the lower middle, where the per annum, the money you earn is about $7,500 per year. So it's 21,000, and they are thinking by 2040 in India, it will be about 26% increase. So molecular testing, as I mentioned, it encompasses everything. It's prevention, treatment, prognosis, and surveillance. Molecular testing is part of the entire gamut of breast cancer. And so I'll start with the germline a little bit. So testing for the hereditary cancers and the hereditary mutations in breast cancer was started in the 1980s. Initially testing, it was basically BRCA1 and BRCA2. However, that was just the beginning, and now then it became looking for large deletions and duplications, then it included POLB2, and now you can essentially get a panel of 25 genes looking for breast cancer predisposition in germline. The problem comes with a lot of issues: is whom do we test? what are we looking for? What else is going on? What do we tell the families? And are all the mutations identified? Are they all pathogenic? That means, do they all cause concern? Because you sometimes have benign mutations, you have variants of unclear significance where you don't know what to do with it. So there are a lot of concerns with doing an expanded panel. I'm not going to go through the germline testing as far as criteria go, because that's it's part of knowledge, but basically breast cancer on or above 50 years, ovarian cancer, pancreatic cancer, makes you think about BRCA1 and 2 testing. The only thing I will say, breast cancer includes both invasive as well as DCIS. So how do we test? One is you do a pre-counseling where you look for the history, you get a pedigree, you see what family is affected with breast cancer. And then you counsel the patient that this is, we may not always find a defect in the breast cancer genes. We may need to do other genes also based on what's going on. Once we get back the results, we then do post-test counseling. Was it positive or negative? If it was negative, are there any other genes to test for? If it was positive, what does that mutation mean? So it requires a lot of thought. It requires a lot of time, as all of you know, when we counsel these patients. So why is that important? Because prior to 2018, there was no specific therapeutic required, for systemic disease. But after 2018, the PARP inhibitors were approved, and they were approved for patients with metastatic breast cancer along with a germline mutation. So now with systemic therapies approved, NCCN, which is the body in the US, basically is considering testing all patients with metastatic breast cancer for a BRCA mutation so that they actually benefit. It's still not standard of care, but it is definitely in talks. So the guidelines have evolved since the 1990s, and now there are other genes, as you can see here, which have a high predisposition for breast cancer. How does it matter? Because there are new guidelines which have developed for these various genes. Also, how do we screen if you have a predisposition for a germline with breast cancer? So, for example, there are recommendations now to start if there's a risk of more than 1%. Some MRI models say screening for breast cancer to see if breast cancer is developed is more than 2%. There are some genes where you really don't know what to do, such as the ATM gene. When you test for, what are your guidelines for screening? It's still not known as well. It's still not defined as well. So when we do test for this, we need to approach this with a grain of salt. So again, as I said, there have been calls for using one single panel, and the US is certainly moving towards that, where they are doing a panel of 25 genes all at once. I've said that it comes with issues, and there's of course, especially in India, an increased cost associated with expanded panels. Your cost will jump from, and can give you in dollars, from about $600 for 2 genes to about $1,600 for 25 genes. Again, not much looking at the span of the number of genes, but if you're looking at a patient paying for it, of course, it's definitely more. So I won't talk about the transcriptome assay too much, because these are like Oncotype DX, MammaPrint, because this is not really NGS. But I will touch upon it a little bit. And I think the other 2 doctors before me covered this very well and extensively as far as ER positive cancer and early stage breast cancer. So germline mutations are rare in this. What the products like Oncotype DX and MammaPrint do, basically look for risks in breast cancer, good prognosis versus bad prognosis. Will they benefit from chemotherapy or not? And they don't use NGS. They use transcriptome assays. Basically, it's on RT-PCR and microarray technology. And that's I guess, because of the wide expanse of the topic, that's all I'll talk about with this. So when we come to testing for somatic mutations, that's where NGS is really used. With advanced cancer, it's basically you sequence the DNA, and it's or now it's RNA, and you do it on the tumor, or you can do it on the circulating tumor cells. So now tumor testing for mutation is performed on large panels, 200 to 600. Do we need such large panels? Probably not right now, we need a panel of probably about 25 genes, right, which are needed, but a lot of panels offer 200 to 600 genes for future research. Then there are, of course, genes which, because of chemotherapy given, you can acquire mutations. So when you have, say, aromatase inhibitors are given, they can acquire mutations in the ESR1, and then you kind of want to stop that chemotherapy and consider others. So I'll talk about the most important genes and why they are done, and what are some of the issues as far as the diagnostics portion of it associated with these specific genes. So PIK3CA is one of the most common genes associated in ER-positive breast cancer, nearly 40% of tumors. And they are driver mutations. They kind of remain consistent between primary and recurrence. Very rarely do they change, or very rarely do you get additional mutations later. So these recent data, however, has shown that acquisition of a particular PIK3CA and ESR1 mutations may accompany resistance to fulvestrant therapy, suggesting that serial determination may be needed. So the jury is out on the PIK3CA as far as, do we do serial mutations or do we not do it? The new emerging data has shown it can, but so far, I guess the data has remained that the PIK3CA is consistent, but newer data just show that serial, evaluations are needed for that, to look for certain acquired ones. So BRCA1 and 2, there are pathogenic mutations about 5% of cancers. And if you see one in the somatic mutation, it is recommended, and it should be done. You need to do germline testing of BRCA1 and 2, because identification of germline BRCA1 and 2, you can give PARP inhibitors with that. And then what is important with BRCA1 and 2 mutations, you can have different kind of mutations. Not all BRCA mutations are pathogenic. In fact, sometimes you have passenger mutations. That is just BRCA mutations which are acquired with time and don't necessarily mean anything. For example, missense mutations, which are basically when there's change of one amino acid to another, are usually passenger mutations and are not pathogenic, are not driver mutations of the disease. The truncating mutations or frame shift mutations, which basically cause the protein not to be formed correctly, are the driving mutations, and those need to be given heat to, and those are the ones that germline testing should be done for also. So it's important that the BRCA1 and 2 mutations be interpreted with care. The NTRK gene is another essential one of them. It's basically, these are fusion mutations. It is usually done in metastatic disease, or if there's been progression on prior therapy. If there was a fusion identified on the NTRK, then we look for what is its fusion partner. Is it an NTRK1 or NTRK3? And that's important because different therapies are based on it. So there are two ways of doing testing on the NTRK. One is DNA and one is RNA. The good thing about NGS, when you do NGS testing, you can look for all the NTRK mutations at one-stop shop. You don't have to do NTRK and then follow up with NTRK1 and NTRK3. You can do all of it together. With the DNA-based NGS, you're not going to get all of them. You get some of them, but it doesn't capture everything. And it's hard to sequence it because of the large number of introns in these genes. So what they recommend is the RNA sequencing. A lot of the DNA based NGS, so let me take it back. A lot of the panels now offer RNA-seq or RNA-seq fusions as part of their panel for sequencing, which includes DNA proteins as well as RNA fusion proteins. Well, how RNA helps is basically the introns don't bother it as much. So you can sequence it better and faster and cover more genes. The problem with RNA sequencing is when the quality is poor, because with RNA it gets degraded very, very quickly. So The sample requirement is a lot more stringent. It cannot be impure or it cannot be contaminated for it to work correctly. The other one done is microsatellite instability is included in a lot of panels. However, what's surprising is the MSI is not very prevalent in breast cancer, only 2%, and that's it. However, it's important because it's high sensitive. If it's MSI positive, then there's immunotherapy available. Why MSI is helpful is because it affects the tumor burden. If the MSI is positive, then usually these tumors are a lot more aggressive, and that's how you want to treat these breast cancers, as more aggressive. There are some other mutations which are common in breast cancer. One is the HER2, or not common, I'm sorry, which are seen in breast cancer. The HER2 mutations, which are not the amplification, just HER2 mutation, is recommended to be done because they may sensitize breast cancer to the dual kinase inhibitor. And if you do, the thing to keep in mind is if you do recurrent biopsies, tumor biopsy, there are no acquired HER2 mutations. It's very rare, especially when it was HER2 negative earlier. Then among patients with triple negative cancer, we talked about the PIK3CA. There's also the AKT and the PTEN, which should be done because of the sensitivity to the AKT inhibitors. There are some investigational biomarkers that are now coming out, like RB1 and FAT1. The RB1, it's still research purposes, but again, with RB1, it's breast cancers have shown to have poor prognosis and higher tumor mutational burden. Again, these are all done as part of the 600 gene panel, which you have. It's important to, again, interpret these with caution because there can be passenger mutations, as I talked about earlier. When is it pathogenic? When is it just a variant of unclear significance? What kind of chemotherapies are available for them? So these reports need to be given a lot of consideration. We talked about tumor a little bit as far as what the panels are, what the genes are. The same thing can be done with liquid biopsy, where basically tumor cells die, a small amount of release DNA is in the tumor, and these circulating DNA, they are suggesting is a way for advanced breast cancer. And I'll talk about a little bit more about how it's being used, and you may not want to use it as screening necessarily or as an initial diagnosis. So it's the circulating DNA is useful to identify mutations in cancer that are not acquired through that are acquired through treatment. So if you give chemo and then, as we talked about, there are mutations that are acquired later on, such as the ESR1, it's useful for capturing that. And other mutations, which show the prognosis of the disease as well as tumor mutational burden. So circulating DNA definitely has a role to play. And I'll talk a little bit more about this as we go through the slides. So the ESR1 we talked about is used for the aromatase inhibitor, and we capture it by the acquired mutations. When we are giving chemotherapy. So an ESR1 mutation is associated with worse outcomes in patients treated with ongoing aromatase inhibitors. And if you have the mutations, it predicts risk to, it predicts resistance to these. So you may want to consider other chemotherapy options available. So as I talked about the liquid biopsy, there are issues, there are good points. Usually a liquid biopsy is, the train of thought right now is to be done with the tumor to capture any tumor heterogeneity. Means basically tumors may have mutations, but not necessarily it may be in the circulating cells. And this is especially in early stages of breast cancer. So when there's a diagnosis made, it's important to do the tumor as well as the liquid biopsy, especially for monitoring stages for later on. So you have a baseline of both liquid as well as tumor. Yes, cost is prohibitive sometimes, but I guess this is the standard of care. There are issues with liquid biopsy, it's still in emergent phases. So there are very few studies that compare the different circulating tumor cells from one assay to the other. I talked about the early stage breast cancer, and some of the, where basically there's very little circulating DNA in the blood. So when there can be issues as far as monitoring, as far as are there mutations, what mutations can we treat? And we need to do it with caution. That's why a tissue along with a liquid at diagnosis is important. However, we can use it for predictive status of breast cancer, right? When we talk about tumor mutational burden, when we talk about how therapy is progressing, we can do a liquid biopsy with that. Especially in the aggressive cancers, tumor mutational burden is definitely helpful. They are likely to benefit from checkpoint blockade therapies. The tumor negative breast cancer carries a higher tumor mutational burden than other breast cancer subtypes. And then the issue with tumor mutational burden is a couple-fold. Number one, what platform are you doing it on? What is your cutoff as far as breast cancer? These are still evolving things. So there are cutoffs for colon cancer, there are cutoffs for melanoma, there are cutoffs for breast cancer, but they are not as well defined. And again, this needs to be taken with a grain of salt, because one of the things what happens is some of them do tumor mutational burden on just a specific panel of genes, and some of the people do tumor, or some of the companies or lab companies do tumor mutational burden on the whole exome, means looking at all the genes. So there's definitely a discordance between whole exome and tumor mutational burden on specific panels. But for so far, the data has shown that whole exome across various assays are consistent. So it's very hard to follow tumor mutational burden by sending it to one lab and then a second test onto another lab. It should be done with one lab, because then the cutoffs kind of remain consistent through that. Then also, so that's, let me see where I am. Okay. So here, these are the different assays which we have, the number of genes. So as in conclusion, I will say NGS is definitely as used in a lot of the breast cancers, right from diagnosis to treatment. These are the genes which have been shown to be very helpful. However, all of this should be taken and managed very carefully, and the report should be interpreted with a lot of care. That's it for me. Thank you.
Thank you.
Boban, would you like to ask some questions? Or
Thank you, Aparna, for that extensive coverage. I know it's like asking you to cover NGS and breast cancer in 20 minutes. It's a very difficult talk, but then you managed to summarize everything in a nutshell. So my question to you is that, what do you see the future is? Like, how long will it take when these tests are becoming much more user-friendly? User-friendly in the sense like economic friendly or pocket-friendly, I would say, so that our day-to-day clinical practice will be, we can have an impact of all this tests in our day-to-day clinical practice. Nowadays, we are restricting it to very selected cases.
Yeah, I think you're absolutely right. So I think in about 5 years, it will definitely be a lot more economy friendly. I do think, however, if you do decide to, the metastatic disease is where I would concentrate resources on. Not so much the early stage and things like that, but the metastatic, especially with NGS, the transcriptome assays and all, probably would be the early stage. The cost is prohibitive, but I think as more companies start in India, I think you'll see the prices go down. Right now, a lot of it is sent out. Not so much, I would say about 60-70% is probably sent out of country.
Thank you. Boban, you would like to say something more?
No, nothing. I think we'll keep the discussion.
There are a lot of surgeons watching, and I thought by the time a medical genetic expert started speaking, they should have left. But I think your talk was so simple and crisp, and it was so understandable. I really congratulate you, and it was unexpected. Thank you very much. And
Chandramohan, I feel like very soon the surgeons also should be able to interpret all this result, because things are changing very rapidly. It will never.
Surgeons are vaccine stock onwards. Surgeons are doing limiting the surgery, radiation. This thing. I think now the main ball game is on medical oncology, but I think that is not going to stay with you guys. It is going to go to the area of genetics or something very soon. I think very soon all the oncologists will be jobless. Okay, so now we are having the young specialist Anjana Joel as the next speaker, and looking at her CV, I understood that she was the best outgoing student of Adayar Cancer Institute in 2017. While she was appearing medical oncology, I happened to be the surgical oncology examiner there, and I used to hear about her, and I'm very happy that she's joining here. And I also learned that she's so many awardees during her young days, including the Torren Young Scholar Award and ISMPO, the gold medalist. And she also had an opportunity to go an Indo-American Cancer Fellowship, which I also availed at some point in time. And she worked with Dr. Jamie Abraham, who is a good friend of us. And we are really eager to listen to you, Dr. Anjana Joel. Please come on and speak.
Thanks for that warm introduction. So I'll just share my screen.
I think Dr. Abarna should delete her screen. We can still see.
And if somebody can just allow me to switch on my video. It keeps saying the host is not allowing me to switch on my video, or yeah. Okay, you can share, you can see my screen, right? Yeah. Okay.
Yes.
Yeah, sure. Okay. Okay, so I think something's wrong with my video, but I'll just go ahead anyway. So what I'll be talking about is about the changing paradigms in HER2-positive early breast cancer. Now, this is the schema of my talk. So what we will go over is that I will just give you a brief introduction. I understand that there are a lot of postgraduates here. So we will discuss what this HER2-positive breast cancer is, a little bit about how the treatment things evolved, about how trastuzumab came into the picture, and what are the various strategies in terms of adjuvant, neoadjuvant, and what we do when there's residual disease post-neoadjuvant treatment. Now, HER2-positive breast cancer is just a type of breast cancer where the HER2-positive gene is overexpressed or amplified. And what essentially happens is that the cell on its surface starts expressing these HER2 proteins. Now, we all know that these tumors tend to be more aggressive, and they don't respond to hormonal treatment. They respond better to chemotherapy and a combination of targeted therapy or anti-HER2 therapy, and sometimes have a poorer outcome in terms of survival with increased risk of recurrence and with a tendency to spread to the brain. Now, this is actually at the molecular level what HER2-positive breast cancer is all about. So this receptor, the EGFR family of receptors, there is HER1, HER2, HER3, and HER4. Now, the HER2 is peculiar because it doesn't have an extracellular ligand to bind to this receptor. And what this does is usually it either does homodimerization, that is two HER2 receptors joined together, or there is heterodimerization, where it joins with either a HER1 or a HER3 or HER4 receptor. And once it does that, the other three receptors can be activated by an extracellular ligand. And then there is downstream activation of various pathways, and then the cell starts proliferating in an uncontrolled fashion. Now, in 2006, the first anti-HER2 drug which was approved is trastuzumab. And this was actually approved at that time in only node-positive, HER2-positive breast cancer. Trastuzumab is actually a humanized anti-HER2 monoclonal antibody, and it's 5% murine. And so this is the structure. It's like a Y, and the yellow part there, that is the antigen binding site. So again, going back to our old diagram, so the mechanism of action of trastuzumab, there are 4 ways in which trastuzumab actually acts. So if you look at, I don't know if you can see my pointer, but if you look at the far left, the panel number C. So what happens is that normally when these receptors are activated, the extracellular part breaks off. So that's called cleavage. And then this phosphorylated P95 protein goes intracellularly and starts activating downstream pathways. Then, so this trastuzumab blocks the cleavage. Then there is also, it blocks the homo and heterodimerization. The panel number E, what happens is that it prevents the activation of ADCC, which is antibody dependent cell mediated cytotoxicity. Sorry, it activates the ADCC and which leads to cell kill. And then it also causes endocytosis of the HER2 receptor, leading to degradation of the receptor. So remember, in HER2 positive breast cancer, the cells express a lot of HER2 receptors. This not only decreases the downstream activation of these pathways, it also leads to these receptors getting endocytosed into the cell, and therefore these receptors, the number of receptors also comes down. Now, the 4 pivotal trials wherein we got evidence to use adjuvant trastuzumab in HER2 positive breast cancer, we started off with the NSABP B31, then the N9831. These both were done in America. Then there was the BCIRG 006, which looked at avoiding anthracyclines, and then the HERA trial, which established 1 year as the standard duration. So now remember, till these trials came around, the standard of care, as usual, was vanilla, just AC followed by a taxane. Now, what these trials showed is that the curve on the left is disease-free survival, and the curve on the right is overall survival. So, in both of these, at 10 years, there was something around a 9 to 11% benefit with the addition of use of trastuzumab as an adjuvant treatment. And those days, the adjuvant trastuzumab would be used sequentially and not concurrently or not neoadjuvantly. So this is only adjuvant trastuzumab, the benefit. Then the BCIRG 006 came along because people realized that there was this issue of cardiotoxicity with trastuzumab. So people were exploring the option of avoiding the anthracycline. They had to give the trastuzumab for 1 year somehow, but can we avoid the anthracycline, which adds to the cardiotoxicity? So this was the TCH regimen as per the BCIRG 006. Now, what we can see very clearly here is that the blue arm is actually the subgroup of patients who did not get trastuzumab, and they did much poorly. And the green is actually the standard treatment arm, which was your AC followed by taxane and trastuzumab, and the TCH is the red arm. So this was actually a non-inferiority trial, and they demonstrated that this was not inferior to the traditional approach and where you could avoid anthracyclines. So this is the similar data for BCIRG 006 in terms of the overall survival. What I just showed you before was the IDFS, or the invasive disease-free survival. So what we concluded at the end of these adjuvant trials is that at 10 year of follow-up based on the NSABP 31 in terms of DFS and OS, definitely there was a benefit of using adjuvant trastuzumab or TCH over a non-trastuzumab regimen. So you have to use adjuvant trastuzumab. Now, in terms of whether do you use TCH or whether you use AC and anthracycline followed by a taxane trastuzumab, the TCH seemed to be non-inferior with less cardiotoxicity. And so that was the advantage of, there was 5 times more clinical congestive heart failure in the AC arm, rather in the arm which got AC and the taxane and trastuzumab. Then once this became standard of care, people started looking at whether we can use even less chemotherapy. So there is a trial called the AP trial, which selected out patients with very early HER2 positive breast cancer. So essentially, these were tumors which were less than 3 centimeter in size and node negative. So these patients only got 12 weeks of weekly paclitaxel and trastuzumab, and then continued their maintenance trastuzumab for 1 year. So this showed, like, these sort of curves most of the time we medical oncologists see only things like Hodgkin's lymphoma. So these straightish kind of curves. So this showed an excellent outcomes in terms of disease-free as well as overall survival. So this can be a standard of care in patients where you have a very early tumor and you don't really want to give much of chemotherapy. Then people said, can we give longer? Would that help? Would it help in terms of better survival outcomes? So that was the basis for this trial called the HERA trial, which looked at 1 year versus 2 years of trastuzumab. So this is again the invasive disease-free survival curve. And what they actually essentially show is that in terms of DFS and overall survival, there was no significant difference whether you used 1 year or 2 years of trastuzumab. And that is how the 1 year became a standard of care. So by then, people developed lapatinib, pertuzumab. So the next question was, can we escalate by adding one more drug to trastuzumab? So I think there were some trials which looked at the addition of lapatinib. Those were kind of negative trials, so I've not gone into it. What is more recent and what we are interested in is does the addition of pertuzumab help? So this was the affinity trial. So this again was a phase 3 randomized trial among patients with HER2 positive early breast cancer who had undergone upfront surgery for whatever reason, were either node positive, so that is a risk factor, or if they were node negative, they had a slightly larger tumor, which ideally we would have given neoadjuvant to, so anything more than 1 centimeter in size. So what this regimen they did was that they just added pertuzumab to the standard of care chemotherapy and trastuzumab, and they looked at the survival outcomes. So their IDFS, which was their primary outcome, there was, even though this may have been called statistically significant, we're not really sure if this was clinically meaningful. There was a 2% benefit. Now, when we go on to remember, this is again an unplanned subgroup analysis. So when we look at, can we identify a specific subgroup of patients who may benefit from the adjuvant trastuzumab? Maybe, because the magnitude of benefit of 3% is slightly more in patients who are node positive, and also in patients who are hormone negative, that is also around 3%. Now, this may be a little bit in context in our Indian setting, mainly because, even though there are tertiary centers and most of us are moving towards neoadjuvant treatment for HER2 positive and TNBCs, there will still be patients who would have undergone upfront surgery, who will come with, say, N2 disease, having undergone upfront surgery. So maybe if we do have patients like that, there may be a chance to give these patients adjuvant pertuzumab, even though in our setting, cost is definitely an issue, and most of us don't really practice this. So then in 2017, this was approved. Pertuzumab was approved in the adjuvant setting in patients who had a very high risk of recurrence. Now, everything comes at the expense of something. So expense money, not just cost, but other side effects also. So with the pertuzumab, we all know, especially when we use 840 mg of pertuzumab in cycle 1 for whatever indication, there is a very high risk of diarrhea. And pertuzumab-induced diarrhea is an issue. So there is almost a 10% risk of grade 3, grade 4 diarrhea when you use pertuzumab as a maintenance. And if you try explaining this to a lady who's thinking, I've just finished my whatever chemotherapy time and can I take a breather now? Most of them will probably even refuse it. So 10% risk of grade 3 diarrhea, 3% maximum benefit in terms of IDFS OS. So there it may be a bit questionable. The other agent which people do use in the West in terms of adjuvant treatment is neratinib. So again, similar subset of patients, we know that neratinib has been used in the metastatic setting in HER2 positive breast cancer. So again, their primary endpoint also was IDFS at 5 years. This is a relatively recent trial, so we don't really have much longer follow-up. Similar numbers like the affinity trial. So maybe 2 to 3% of adjuvant benefit, and the benefit was probably much more pronounced, as we know, in the subgroup of patients who are hormone positive rather than hormone negative. Now again, neratinib also is a very toxic drug to give. There is a 40% risk of grade 3 diarrhea, and definitely it is not accessible to us in India. And even if it were there, I doubt whether many of us would be using it because of this diarrhea issue. Okay. Now, moving on to from escalation strategies, moving on to de-escalation strategies. Now, again, in our setting, there is the question of, can everybody take trastuzumab? Can everybody take little trastuzumab?
Excuse me, Dr. Anjana.
Yeah.
Yeah, your slides are not moving. Can you just check it out?
1 second.
We're still in slide number 14 over here.
Okay, just a second. I'm just sharing it again. Yeah, is this okay? Are you able to see it?
Yeah. Can you just put it up in the slideshow mode?
Done. Can you see it now?
Not it. It's in the other mode.
No, it's there in the slideshow only. It is in slideshow only. 1 second. Is it moving at least?
No.
Not moving. Okay, 1 second. Maybe I'll just stop share and I'll redo the share. Sorry.
No issues.
Is it okay now?
Oh, yeah. Now
Okay.
slide 27, we can say just.
Yeah, I am so sorry. Okay,
Yeah.
so when we move on to de-escalation strategies, so there is
Can you
also
just go a bit faster because we are already 8:30, 8:20. So just.
okay, all right.
Yeah.
So in terms of de-escalation strategy, there is a lot of data looking at anything short as 9 weeks to 12 weeks to 6 months. So short duration trastuzumab again is an option for patients who have maybe early stage 1, stage 2, which limited nodal burden. So there is some data now with the trial called the Persephone trial, which looked at 6 months of adjuvant trastuzumab. That again showed that 6 months was non-inferior to 1 year of adjuvant trastuzumab in terms of DFS and overall survival. And more importantly, the cardiotoxicity was reduced by 50%. So now moving on to neoadjuvant treatment. In terms of neoadjuvant, again, traditionally what people have been doing is that neoadjuvant treatment was reserved for patients who had very large breast tumors to somehow enable them for surgery. So the approach now has changed. We use neoadjuvant treatment, especially in certain patients who are, say, HER2 positive or triple negative, to increase the risk of a pathological CR. Now, the pathological CR is again being termed as a surrogate for survival outcomes. And there is some data both in these two subset of cancers that these patients who get a PAT-CR have a better outcome than the ones who don't. And it also allows us to use this approach called a response adapted treatment, which has been used in other cancers. So the NOAA trial looked at the neoadjuvant use of trastuzumab, and what they essentially found is that the rates of PAT-CR went up to as high as 60% versus 26% when we use neoadjuvant trastuzumab. And this was associated with a big survival outcome in terms of event-free and overall survival. And then, we looked at the addition of pertuzumab. Now, pertuzumab, again, works in a different fashion when compared to trastuzumab. It binds at a different subdomain at the extracellular level. So the evidence for the neoadjuvant use of trastuzumab is mostly from two trials. One is the Neosphere trial. And what the Neosphere trial essentially showed is that this looked at a combination of THP, which is a taxane, Herceptin, and pertuzumab. This combination had the highest pathological CR, as high as 45%. And the next trial, which looked at something similar, was the Trifina trial. But the Trifina trial was a phase 2 trial, mainly to sort of look at the cardiotoxicity with this particular combination. So in the Trifina trial, they actually did 3 cycles of THP followed by FEC, and they also showed similar high PAT-CR rates with the use of 6 cycles of TCHP, which was trastuzumab, pertuzumab, carboplatin, and the taxane, docetaxel. So then there were other trials like the Bernis trial, which was also along these lines, which looked at just AC followed by a taxane and pertuzumab and trastuzumab. This was mainly to look at cardiac safety. So I will probably just skip this and go to the last trial, which actually looked at, again, a de-escalation strategy while using the dual HER2 blockade. So do we really need to use 2 drugs? So this HER2 trial is actually, again, a subgroup of HER2 positive patients who are ERPR negative. We know that the patients who are ERPR negative and HER2 positive actually respond the best to the neoadjuvant treatment. So what this trial they did is that they tried a chemo-free regimen, which is only trastuzumab and pertuzumab for 12 weeks versus weekly Pacli with this combination for 12 weeks. And actually what was interesting is that there was almost a 30% PAT-CR with only the use of trastuzumab and pertuzumab. And again, a PAT-CR of almost 78% with the use of just 12 weeks of Pacli and trastuzumab and pertuzumab. Now, this trial, again, this trial was closed early because of early interim analysis. And then we really don't know what were the treatments which was given to the patients, especially in the arm which got trastuzumab and pertuzumab alone after they didn't get a PAT-CR. So remember, only 1/3 got a PAT-CR. But whatever these treatments were, the IDFS was, not too bad. So 80 versus 98% in the other arm, and 94, and the OS was also significant. So unless we have data about those post-trial interventions on what exactly we did, we'll have to take this data with a pinch of salt. But this is definitely an option in somebody who maybe we really want to avoid chemotherapy, or you want to sort of de-intensify chemotherapy for whatever medical or surgical comorbidities that they have. And in this subgroup of patients, there was just one subgroup, the basal subgroup, or the patients who were just only HER2 1+ or 2+ on IHC and only were FISH positive. Those patients actually didn't respond that well to this regimen. So that is something which we should keep in the back of our mind if we ever consider this regimen. So to conclude, any treatment of HER2 positive breast cancer has to be done based on an MDT, depending on what is the stage and what is the type of surgery that you want to offer, and what are the patient's comorbidities. So any HER2 positive tumor which is more than 2 centimeter, or of course if it is node positive, should be offered neoadjuvant treatment. And pertuzumab definitely should be offered to them in combination with the standard of care, which is at least chemo and trastuzumab. And also this will give us a lot of opportunity to de-escalate and escalate also based on whether or not they have a complete pathological response. So I have not gone to what you do for people with residual invasive disease. I think that this is a lot. So thank you for your attention. Thanks.
Thank you, Doctor.
Yeah. Mohan, go ahead.
Yeah, thank you. I have one question to you. It's like, see, there are so many things to be asked on a HER2 positive breast cancer patients. But then my question is like, in your practice in adjuvant setting, do you give 1 year of adjuvant trastuzumab, or you're happy with reducing the duration of trastuzumab to 6 months?
Actually, in our practice, what happens is most of our patients can't afford 1 year. So we do offer 1 year to the ones who can, that is still the standard of care in our setting, and we do offer it to most of our patients. But in the odd, even, I mean, and for us, again, you know, most of our patients, we try and apply for funding from other centers. So if we have the funds, we do 1 year. Otherwise, we stop early. We stop early.
So since you're working in an academic center, my second question, continuation to that, do you have any data for people like me who are in the private sector on practice? So we are forced to be, we don't have that luxury of working in academic center or this data, or doing collecting the data and all. So what is your advice to an oncologist in a peripheral center? So can we get away with this 6 months if a patient cannot afford, or what is the evidence for that thing? Do we have any Indian data to say that, okay, 6 months is as good as 1 year, or at least good as 1 year?
Okay, so in our center, we do have some, we just recently published one retrospective data set in eCancer. So in our center, this was around 130 patients, where this actually we were looking at biosimilar versus, you know, is biosimilar trastuzumab as effective? So in that data set, actually our PCR rates were around 25 to 40%, and our DFS was actually much higher. It was around 80% at 3 years. But then this is retrospective, and you know there may be you know, the retrospective studies often tend to kind of overestimate the outcomes. And in terms of duration, I would say at least 12 weeks of trastuzumab if it is feasible. And in our data set, even though it was a very small data set, what we found is that people who had trastuzumab for more than 12 weeks actually had a better outcome in terms of OS than the ones who had for less than 12 weeks. But then this again is a retrospective data set, and these patients were mostly recruited, you know, like maybe it was a mixed bag of neoadjuvant versus adjuvant, because these were some of our earlier patients. Now we have moved on mostly to mostly neoadjuvant practice only. So if we can update our data, you know, maybe 5 years later, it would show a different picture, I suppose.
Just one more question. If it is a HER2 positive patient, do you feel that, okay, patient should be given Taxol trastuzumab ahead of anthracycline, or you feel that, okay, anthracycline can be given and then you can give a taxane trastuzumab kind of a thing?
So what?
These are all very practical questions I'm asking. So just,
yeah. So if we are, the thing is, if we are deciding to give anthracycline first in our center, what essentially it means is that that patient cannot afford trastuzumab. So what we do is we often apply to the Indian Cancer Society for funding. So we do the 4 weeks of an anthracycline based chemo, and then, you know, by then the ICS funding comes, so we switch. But in somebody who can afford the trastuzumab, we sort of, you know, maybe try and avoid the anthracyclines totally and go with the taxane trastuzumab, or with say carboplatin first, or even add pertuzumab. So yes.
Thank you. I think we'll move. Chandramohan will go ahead with
Sure,
it.
sure. I think
Thank you, Anjana. Thank you. Just kindly stay back for the panel. If time permits, we can have a discussion at that.
All right.
I think this needs a lot of discussion because all these guidelines, when they apply in India, there are a lot of economic implications, and I don't know how far we can do that in the larger setups. So we'll discuss that further during the panel discussion. And now we'll go to the next talk by Dr. Arun Warrior, and he's a consultant of medical oncology, Aster Medicity, Cochin, and he'll be talking about the patient-reported outcome in patient with the PIK3CA mutated hormone-positive, HER2 negative advanced breast cancer from SOLAR-1 trial. Over to you, Dr. Arun Warrior.
Good evening to all. Thanks to Trivandrum Oncology Club for giving me an opportunity to participate in this Breast Cancer Update 2021. So, being the Breast Cancer Awareness Month, I am sure the previous speakers would have discussed in detail about the advances in various fields. My topic in the next 15 minutes is about a slightly different one, that is from a patient perspective, what the patient feels. So I think that is a key question in any metastatic disease. So this data is about the patient reported outcomes in patients with PIK3 kinase mutated, hormone receptor positive, HER2 negative, advanced breast cancer from the SOLAR-1 trial, which was the registratory trial for alpelisib. So these slides were provided by Novartis. So as we go in this presentation, you will understand why I am talking about the importance of pain and its impact on the quality of life for a breast cancer patients. From our clinical practice, we know that pain is the most worrying thing for any cancer patient, particularly in breast cancer. They have pain due to various reasons, and we find it quite difficult to manage that. So if we want really data for this, we have that. So they're quoting this paper from 2017, which deals with the pain and quality of life in breast cancer patients. And it shows that across the spectrum of breast cancer patients in early, locally advanced or metastatic stage, pain definitely compromises the quality of life in patients with breast cancer, particularly those with advanced stages of the disease. So the chronic pain, fatigue and impaired quality of life are there with advanced breast cancer, and how best to reduce their intensity is the challenge which we face. So the subset of hormone receptor positive and HER2 negative comprises around 70% of all breast cancer cases, and health-related quality of life is an important factor in assessing the risk-benefit profile of treatment, particularly from a patient perspective. So all of you would have heard about the details of a SOLAR-1 trial, which was reported in 2019, that evaluated the combination of alpelisib plus fulvestrant, and they had this health-related quality of life subset was also there, which was later reported in 2021. So the strategy of adding targeted therapies to endocrine therapy before initiating chemotherapy implies that these treatments maintain quality of life. And all of us are very familiar about the impact with these drugs have made, particularly CDK4 inhibitors have made when we combine them, and we know that the quality of life is maintained for a long time. So how to optimize this further was the question which they tried to answer in the SOLAR trial. So PI3 kinase pathway, just to review it once more, is frequently altered in hormone receptor positive breast cancer, and it has been implicated in resistance to the endocrine therapies. And 40% of hormone receptor positive breast cancer harbor a PIK3 kinase mutation, which leads to hyperactivation of this pathway. And PIK3 kinase signaling promotes an estrogen independent growth of ER positive breast cancer cells, and this growth is inhibited by addition of PI3 kinase inhibitors to anti-estrogens. So the theory behind adding the PI3 inhibitors is very strong, and because of that reason itself, we know that it will have a major role in the management of advanced breast cancer patients. So this data is from various trials from 2009 to 2011, and these trials all helped us in understanding this pathway and how it can help in optimizing the management of breast cancer patients. So selective inhibition of PI3K alpha isoform is a promising strategy in such cancers. So there were various type of drugs were developed, like pan PI3 kinase inhibitors and beta sparing inhibitors were there. So alpelisib is unique in that it binds to the PI3 kinase C alpha isoform alteration. So the side effect profile is actually better with this drug. And there was a phase 1b trial which was reported in 2014, which showed that the median PFS with alpelisib plus fulvestrant was almost 9 months in a heavily pretreated group of ER receptor positive patients with this mutation. So that was the basis of alpelisib being used in this subset of patients in comparison to the other pan PI3 kinase inhibitor. So SOLAR-1 in 2019, it was published in NEJM by Andre et al., which shows in the group of postmenopausal or females or men with HR positive HER2 negative advanced breast cancers who had a measurable disease, they were included here. They were stratified based on presence of visceral mets or whether they received any prior CDK4 and 6 inhibitor therapy. This subset was less because it was done maybe 5 to 6 years back. The trial would have been done, and at that time the use was not very common. So that subset was there, but very less. And the two groups were there, the mutant cohort and the PI3 kinase non-mutant cohort were there. The numbers were balanced, and it compared placebo plus fulvestrant to alpelisib plus fulvestrant. The PFS was reported, and the primary endpoint was PFS. And the NEJM article showed that the PFS was better. The median PFS was dramatically improved in the subset of the mutant group. It was 11 months versus 5.7 months. So the mutation status was taken from the tissue samples, and similar results were done with mutation from circulating tumor DNA also. And as I told before, a very small percentage of patients only had received prior CDK4 and 6 inhibitors. So I think we had previous talks also about this subset, so I'm not going to the details of the SOLAR-1 trial. So we know that the PFS was really improved in the subset. But the main issue was the adverse event profile. Hyperglycemia, a class effect of these drugs, was definitely a problem. Almost 1/3 of the patient had a grade 3 hyperglycemia, and the management is a challenge for the clinicians. While the other side effect, like we expect in other TKs, like diarrhea, nausea, rash, vomiting, were all reported in the alpelisib group, and the numbers were higher when compared to the placebo. So the clinicians were worried about whether the adverse events can really impair the quality of life and whether this can negate the 5 months advantage in PFS which we gain by using this potent molecule. So we had to wait for 2 years from 2019 from the publication of the original trial to 2021. So this was a JCO article which focused on this subset. This was published online in March 2021, and this deals with the patient reported outcomes, or PROs as it is commonly called, in the patients who received alpelisib in the SOLAR-1 trial. So the patient-related PRO assessment was done. The two tools which were used were the EORCTC tool. All of us are familiar with this. So that is, it has stood the test of time from 1995 onwards for the past 25 years. It is still one of the major tools which is used. And the other was the brief pain inventory, again, which was developed in the 1990s. So EORCTC quality of life, we know. It is a patient reports whether during the past week they had various problems, and all of us would have done this as part of some data which we collect from our patients. So they report whether it is impairing, not at all, a little was impaired, quite a bit impairment was there, or that was very much impaired. So it is definitely depends on how the patient reports this, and there are various aspects: physical, social, emotional. All these aspects are taken into consideration, although they don't mention it in the data sheet or the questionnaire, but it is designed in a way that it will capture all these important things. So most of the drugs have to go through this quality of life thing, and it's an important part of management of advanced breast cancer patients. So this is the brief pain inventory. short form. So it is again, I couldn't get the original thing. This is just an image which shows, because it is a licensed thing. But again, I don't think we are familiar with this, but again, it deals with various pain location and pain severity with the patient reports. And it is again analyzed at frequent time intervals during the treatment of the with the drug. So these were the two tools which were used to understand the PROs. So first going to what happened to the EOS CTC QLQ C30 in the global health status, what happened? So global health status and functional status were maintained from baseline in the alpelisib and placebo arms. So the main worry whether the side effect profile is affecting or not is not was not reflected in this, and the median change, though a significant median change was a change of at least 10 points, was not seen there, was not seen in either arms. So over weeks, that is from week 0 to the patient to the week 56, the quality of life was maintained. And again, the various aspects, as I told before, the physical, emotional were maintained, while the social aspect was impaired in the alpelisib arm. So we will be coming later why this was affected in the alpelisib group. Otherwise, in the other subset, there was an improvement was there. So this is about the global health status. So one more terminology which they come here is, what was it, time for 10% deterioration. So TTD. TTD is used in various trials. There are the various ways in which it is described. So here, just remember that it was time for 10% deterioration. So over a period of time, well, if the drug is really affecting the quality of life, the TTD is going to be different. But again, compared to placebo plus fulvestrant and alpelisib with fulvestrant, the TTD were consistent and did not demonstrate difference between the two arms over 28 months. So it was remaining, the curves were remaining similar. Even though the alpelisib had a better PFS, somehow the time for 10% deterioration of the quality of life was not significant in the placebo arm also. So maybe some of the side effects balanced each other, and patients, because they could live for a longer time, maybe that was the reason. So that was one of the things when we go through the article, because they could live for a longer period. So maybe that was the reason why the curves were not different. Now the next aspect is about the functional subscales. That is the physical and emotional. Definitely, it favors the alpelisib arm, although not dramatically, but still it was favoring. I think they were happy that it was not worsened, because the main problem, the worry with alpelisib was the side effect profile. So even though it was not statistically significant, it was favoring. They were happy with these outcomes. And the other functional subscale was a social subscale. Again, there was a problem there because of the diarrhea. It was almost 1/3 of the patients had diarrhea. So because of diarrhea, the social activity was definitely impaired for this 1/3 of patients, which would have led to the results favoring placebo. I think that is a very sensible explanation why the social aspect was better in the placebo group. And the time for 10% deterioration analysis of functional scales again showed there was no statistical difference was there in the subscale scores. So it's fine. And again, symptom was again looked at here. So the symptom subscale. So pain, fatigue, nausea, vomiting, dyspnea, all these were analyzed here. And the treatment difference was better in the pain, dyspnea, and insomnia and constipation group. So constipation score was improved in the alpelisib treatment. I think there is no prices for guessing why it happened, because almost 1/3 had diarrhea. So definitely constipation arm was better in the alpelisib. It is just a statistical thing. So I don't think it makes any clinical difference. So there is no reason for that, because they had more diarrhea. So the constipation was, that's all. Otherwise, I think we should be focusing on the improvement in the pain, dyspnea, and insomnia, which was slightly better with the alpelisib group. Okay. Now coming to the brief pain inventory short form, which deals with the worst pain pain severity index and the pain interference index analysis. So definitely worst pain and pain severity index showed that there was a delay in the worsening of pain and pain severity in the alprazolam. And at week 24, just remember that the median PFS in the placebo was around 5 months. So I think by week 24, many of them would have progressed. So that would have been the reason why at week 24, because more were remaining on alpelisib. So the pain improvement was better there, while the placebo had a higher pain worsening. So they had improvement was seen in the alpelisib arm. And it was continuous also. So they lived for a longer period of time, and the improvement in pain was also maintained, which is a good thing for the drug. So when in conclusion, they summarize that there was no statistical difference. So in the deterioration of global health status or quality of life. Remember that alpelisib was reported to be a highly toxic drug from the community. So that was the reason why they did all this analysis. And one main thing was about the diabetic patient, what happened to them. So if you read the article, there is a subset. They are told about a diabetes subset also. And if the diabetes was properly controlled, then they concluded that there was no difference in the quality of life in the patients who had hyperglycemia and the patient who did not have hyperglycemia. So that was an important thing to be which I understood from this article. And the physical, emotional, cognitive, and role functioning scores were similar to those observed in the placebo group. So this is again a good thing, and I feel that as clinicians, and particularly when we are dealing with more and more of metastatic breast cancer patients with more toxic therapies and more costly therapies also, we should try to look at whether we are really improving these things. So in our clinic also, we are trying to analyze this quality of life for at least some of our patients. Although not everyone can be persistent and not everyone can give a good answer to these questions, but it is still possible, and I think we should try to do that so that it reflects what we are really giving to our patients and what is the real benefit they get from the treatments which we give them. So that is one message from this trial. So clinical decisions must consider efficacy, tolerability, which we are very sure about this. And this results support the benefit risk profile along with the statistically significant and clinically meaningful PFS observed with the addition of alpelisib to fulvestrant in this subset of patients, which comprise almost 70% of advanced breast cancers. So just reminding all of you that in addition to the PFS, OS and other things, try to focus on these quality of life scales. And I am sure that if we try to do this for our routine patients, we will be able to understand how they are responding to this treatment in a better way. Thank you, and we'll join for the panel discussion later for the questions.
Thank you, Dr. Arun, for a fantastic talk. I think really today's entire concept is moving towards de-escalating surgery and looking into quality of life and making the patient better. I think that's the right way of going ahead. So without wasting much time, let me invite Dr. Boban for concluding the final remarks and some issues in the which came up in the meeting, like a panel discussion or case-based scenario, and concluding the meeting. Dr. Boban, over to you.
Yeah, thank you, Chandraman. Can you just switch on my video because I'm not able to do.
Co-host, you should do it. You can do it. Yeah.
Is it visible, my slides?
Yeah, only 4 slides. Happy to see that.
Yeah, only small things. Yeah. Not even small, it's only 3. Okay, thank you also. It's not going to be a panel discussion when I won't be discussing any cases or anything like that. It is just a clinical scenarios, which clinical situations I would call. So we have a medical oncologist, surgical oncologist, radiation oncologist, a molecular oncologist also in the panel. So my question to my medical oncology colleagues, Dr. Arun and Dr. Anjana, is like, do you use NGS in your clinical practice? So if what frequency or how frequently are you using this test in your clinical practice? Dr. Anjana?
So I think in terms of NGS, we recently, just around a month ago, we established our in-house.
Can just be a little bit louder because I think it's...
Okay, sorry.
Yeah.
So we managed to establish our in-house NGS only very recently. Only this month we established it. So most of our NGS was being outsourced. So in terms of when are we using it, like in what setting are we using it, mostly in metastatic setting, not even a diagnosis. I would say most likely post progression, maybe a couple of lines. Actually, majority of NGS was getting sent like that only with respect to breast cancer, sir.
Okay. I don't. What's your experience? Because Anjana works in an academic center and you work in a private sector.
Yeah.
So what is your experience or how do you take it?
So NGS, what? I'm audible, no? Audible?
Yeah. You're audible.
Am I audible? Yeah.
Yes, sir.
So basically, NGS, I'm not a big fan of NGS. Generally, I reserve it for patients who really ask for that. Because in breast cancer, there are a lot of options are there. So we try to go with those options. But I've done in breast cancer only for a very few number of patients. And we know the reports, how it comes and the problems with that.
Okay. So you use use it for a metastatic setting or in adjuvant setting?
NGS, you are asking about the prognostic, molecular prognostic.
Yeah, prognostic. But NGS, I mean, from the talk.
Okay. Yeah.
I mean, I include both.
Okay.
Not only NGS, but other tests also, like Oncotype DX, MammaPrint. Do you? How frequently you are using?
A couple of very rare, maybe one or two cases in a year. That's all.
Okay.
Yes.
So, do your patients come and ask for all this tests, or do you give that option, or the patients come and because you are working in a quaternary center?
I do that because at least 60% of patients which I get are T2 lesions, N1 lesions and all. So in them I tell about this option which is available. Will take the chemo and leave. That's what finally happens. But I make sure that I give them this option. Yeah.
Okay. Dr. Raksina, are you there?
I'm here.
Yeah. Raksina, what is your practice from RCC? Because you're working in a totally different setup. So what is your practice and what kind of tests are you doing? Or do you discuss with your medical oncology colleagues or your surgery medical oncology colleagues discuss this test with you?
No, actually, at RCC, we advise the testing, the surgical oncologist, and we have a tie-up with RCGB, where we're doing specific gene testing for BRCA1 and BRCA2. So basically, we offer prophylactic bilateral salpingo-oophorectomy to the patients who are positive. So we have done quite a few patients. We are not yet analyzed the data, but majority of our patients are negative.
Okay.
It's done at a low-cost setting at RCGB.
Okay, that's actually interesting news because we were not aware of that part. So it's good to know that, okay, you are collaborating with RGCB and then started doing this BRCA testing and started even doing a prophylactic bilateral mastectomy kind of a thing.
No, we are not doing mastectomy, we're doing salpingo-oophorectomy.
Salpingo-oophorectomy, okay, not doing mastectomy.
No,
okay,
no.
Okay.
Yeah.
So just eagerly waiting for the data to be published so that we have an in-house, what do you call it, Kerala data, so that we can actually rely upon.
Yes.
So in metastatic setting, I know that you are not dealing with metastatic disease. In metastatic setting, are you aware of how frequently your colleagues are doing any of this newer generation testing as far as the breast cancer is concerned?
I think Rajiv would answer that better.
Yes, Rajiv?
Yeah, we don't do it routinely as already. We don't do it routinely. And for the adjuvant this thing, as Arun said, for the oncotype this thing, we do have a few number of patients. I think so for each consultant, maybe 5 to 6 patients per year. No. So the other one, this is very rarely we do.
Okay. There are so many things to be discussed, but we are because of shortage of time. This is just having a very superficial discussion on this topic. Slides are not moving. Okay, the other question was to Rexina that she discussed already. That was on the use of sentinel node biopsy in patients who receive neoadjuvant chemotherapy. So if a patient has come, a patient had node positive disease, and then she had a very good response to chemotherapy. Do you do a node sentinel node dissection, sentinel node, or you are comfortable doing sentinel node in that scenarios, or you are happy, you are straight away doing node dissection for those group of patients?
We are currently doing complete axillary lymph node dissections. We have not yet started the clipping and targeted axillary dissection. Because if you see the evidence also, it's based on very small number of trials, a small number of samples in each trial. Is almost less than 100 in most of the trials. And there is no long-term data also. So maybe we'll do a trial and then see how it goes.
So Dr. Aparna, are you still there? I think Aparna has left.
No, I'm here.
Oh, okay, you're there. Okay. So my question to you is like, will a molecular testing will be we will be able to identify the group of patients who are going to respond to a neoadjuvant treatment? Because my question is like, even we all know that there is primary resistance and secondary resistance. So many a times when you're starting a patient on a HER2 positive disease, we tell the patient that we are giving a targeted therapy, but in a good minority of patients, it comes to a situation where the patient has not responded to this targeted therapy, be it anti-HER2 therapy or whether it is an hormone positive tumor. So do you think that, okay, we should be doing this primary resistance care? Do we have any mechanisms by which we can identify primary resistance upfront?
Nothing upfront except for pharmacogenomics so far. I mean, it's been well documented in tamoxifen therapy and a couple of others, but not so much with the others. What's been shown, interestingly, is the acquired mutations and so if they say to start the therapy and do it, unfortunately, there's nothing right before starting it. It would have to be done later, as far as if the patient's not responding to protocol. I do think that will change in a few years again, because there's data being shown, especially with the immunotherapy and with the endocrine therapy, with the some mutations up front, but it's still in process.
Okay. So it's good to hear that, okay, this very soon this kind of testing will be coming into your day-to-day clinical practice. So my last issue, which I'm going to raise, because we have only 2 more minutes. Rajiv, I asked you about this radiation therapy thing, because if you remember after your presentation, because we mentioned that radiation therapy is not giving us a survival advantage. So my question is like, have we reached a stage where but it gives local control? So have we reached a stage where can we get away without surgery, at least in a minority of patients? So a patient had come with a locally advanced breast cancer or a localized breast cancer, we gave chemotherapy and targeted therapy, and we are achieving a complete response. So clinically, there is a complete response. Radiologically, scan-wise, MRI-wise, there is a complete response. And we are doing a PET scan also, and PET scan is also showing a complete response. So are we or can we get away without surgery in this group of patients by giving radiation therapy alone?
It's a difficult question to answer, because I don't know the answer. That is the basic thing, because there is no data as of now in breast cancer where we can avoid surgery and doing radiation and to see the response. So so I don't know the answer. And the other thing regarding the survival pattern is that, as from the VCTCG analysis, where you know that if you reduce the 4 local recurrence, you can reduce 1 breast cancer related mortality. So that is the importance of reducing the local recurrence. So that is where the radiation has got an important factor.
The reason why I asked you this question is like, breast being an organ that is situated outside, we will be able to identify a local recurrence much earlier, unlike any other malignancies. So if you are able to identify a local recurrence earlier, we can we can interfere or intervene at that time, and then get away and take the, and what do you call, and remove the tumor, or the local control can be achieved. So the advantage of taking up an approach like that is that we can get away with the toxicities of axillary dissection, something like lymphedema and all. So even now I see patients coming up with a report of 23 to 24 lymph nodes have been removed, and there are absolutely 0 out of 24 lymph nodes are negative, and patients are doing a breast conservation surgery or mastectomy, and then subsequently patient will be receiving radiation also. We know that this group of patients are going to come back very soon with lymphedema. So can we get away without, at least in those group of patients, can we get away without surgery by targeting only radiation, and we can reserve surgery or axillary dissection or surgery for the group of patients who recur?
Yeah, I think the concept has to be totally different for the primary, and that's for the axilla. And the axilla part that you have said is absolutely right. And we are de-escalating too much, where we are totally avoiding axilla into either surgery or radiation if the sentinel node is negative. So whereby we can reduce lymphedema too much. And even if you want to address the axilla, that has to be with a single modality, either surgery or with radiation. Even if you do a sentinel node, and if you don't want to dissect, okay, you radiate, otherwise you don't irradiate. So but for the primary part, so I don't know, it's almost like doing your urgent treatment, chemoradiation rectum, and can you avoid the organ dissection, where you can, the same sort of thought that what you mentioned is happening there, but I don't know whether that sort of this thing is acceptable. And radiation per se is not a substitute for surgery, and where radiation is irradiating the micro disease, and especially where the recurrence is much more in the tumor bearing region. So that is why the APBI concept has come. And I don't know how much that is going to, sort of clearly tell us if you have a clinical complete response or radiological complete response is going to be the actual scenario where the microscopic tumor cell is, and then the total concept of what is the margin status and all these things might go on. So it's totally a difficult scenario to answer on to the primary. For the axilla, yes, absolutely, we have de-escalated too much.
Dr. Anjana, my last question to you is that, Raksina?
Yeah, see, actually, there are multiple small studies like the MICRA trial, where they're trying to see whether we can avoid surgery to the breast, where they're taking multiple vacuum-assisted biopsies from the breast. And but however, the sensitivity and all has been very low, because all CCRs are not equal to PCR. And then again, there is the question of, if you avoid the surgery, what about the cases where you want to give adjuvant therapy based on the residual disease, like your capecitabine and such things. So until we come up with a proper technique whereby we can actually say for sure that there is a PCR achieved, it'll be difficult to eradicate as surgeons for the time being.
Dr. Anjana, in this era of modern oncology, modern chemotherapy, drugs, and targeted therapy, do you think that doing an axillary dissection that is actually giving a survival advantage, or what are we trying to prove by doing an axillary dissection?
When I look at patients who've undergone axillary dissection, sorry. So for me, if our patients can avoid that axillary dissection, there is nothing like that, because often it comes with a lot of morbidity. So definitely, at least in subsets like our HER2 positive group and everything. So there is always a scope to avoid unnecessary dissection of the axilla. So, but then, yeah, it is a tough one.
Yeah. So medical oncologists have a different view of axilla. Surgeons have a totally different view of axilla. The radiation oncologists have a different view of axilla, at least for the breast. For breast cancer, we all view, even though it is a common thing which we all deal with, but we all view the disease in 3 different ways. We can have so many issues and we can continue this discussion, but then we have shortage of time. So I would like to thank all the speakers. for making this, making it up and having a very lively discussion and a lively talk. So I'd like to thank the supporters, Roche, Novartis, and Metropolis for the unconditional educational support which we have provided. And happy to announce that Trivandrum Oncology Club has completed 10 years. So during the COVID time, our meetings were a little bit restricted because there were multiple meetings were there, were industry sponsored, hospital sponsored, small association sponsored. So it's actually, we are doing a TOC meeting after quite some time. So as Chandra Mohan mentioned, very soon we will be coming up with a physical meeting to celebrate the 10 years of Trivandrum Oncology Club. So thank you all, and see you all soon. See you all very soon. So good night, friends. Thank you.